Hello, this is Sudharshan, and in this episode PH 1.32 we will talk about drugs in the treatment of bronchial asthma. So coming to the different classes of drugs we will see. So 5 classes are there. We have bronchodilators, in that 3 subclasses: sympathomimetics, methylxanthines and anticholinergics, and then we have leukotriene receptor antagonists, then mast cell stabilizers, then glucocorticoids and anti-IgE monoclonal antibody. Let us start with bronchodilators. So these are the drugs that will increase the size of the bronchi. So mainly we have the drugs first, sympathomimetics, that will increase the sympathetic tone. So we have first the beta-2 agonists, that is divided into SABA or short-acting beta agonists, and then LABA, long-acting beta agonists. So short-acting beta agonists, we have albuterol and terbutaline, and long-acting beta agonists, we have salmeterol, formoterol, salbutamol and bambuterol. Okay, so with respect to some important points, so mainly they will bind to beta-2 receptors in the lungs and cause bronchodilation. And with respect to albuterol, the trade name is Proventil, and it is also given in the treatment of angina and also to treat bronchospasm, and with the side effects it will cause reflex tachycardia, flushing, hypotension and tremors. And with respect to terbutaline, the trade name is Brethin. So this terbutaline mainly should not be given more than 48 to 72 hours because it can lead to maternal cardiac complications and death also. And with other side effects, hypotension, flushing, reflex tachycardia, constipation and hyperglycemia also can occur along with tremors. Right. And in general, with respect to the side effects of these, they mainly cause increased sympathetic tone, and in general for pharmacotherapy long-acting beta agonists are preferred because of their obviously long mechanism of action. And the pharmacokinetics are normal with the drug interactions. LABAs are long-acting beta agonists, are generally combined with anticholinergics and glucocorticoids, especially the systemic ones. Right. And then we have the beta-2 agonists. Apart from that, they also cause other actions, like they act as tocolytics or uterine relaxants. Then apart from that, they cause glycogenolysis. Then they increase the potassium uptake in the cells. These are the other actions. Okay. Next, let us, and also the form of administration is through PMDI or pressure meter dose inhaler, very commonly given, or as a rotahaler also. And next we have the methylxanthines. The suffix of these drugs is phylline. So theophylline, aminophylline, etophylline and doxophylline. The mnemonic to remember is DATE or DATE. D for doxophylline, A for aminophylline, T for theophylline and E for etophylline. So the main mechanism of action is it is a phosphodiesterase inhibitor. It increases the levels of cyclic AMP and in turn activates protein kinase. That is the mechanism of action and main use for the treatment of bronchial asthma and COPD. With the side effects, they are not much preferred nowadays because of the toxic profile. So mainly it affects CNS, GI, heart and kidney. In the heart, it increases the heart activity and also constricts blood vessels. Because of that, hypotension, palpitations, arrhythmias can occur. GI distress like abdominal pain, nausea, vomiting. Neuropsychiatric symptoms like restlessness, insomnia, headache, tremors, etc. In the kidney, mainly it causes diuresis, and sometimes even neurotoxicity also is there. And with the drug interactions, It will interact with P450 inducers or inhibitors, even with adenosine. That is also another drug. The trade name of it is adenocard. Yeah, so basically blocks the adenosine action. It will also interact with the sympathomimetics. So that was with the methylxanthines, and also methylxanthines are also combined with caffeine as well. Caffeine. Right. And next we have the anticholinergics. They are the atropine substitutes like ipratropium bromide and tiotropium bromide, which is used to treat bronchial asthma and COPD. And out of these two, just the important point is tiotropium bromide has a long duration of action and hence much more preferred than ipratropium bromide. Mainly they don't affect mucociliary clearance. They don't clean off this mucus which is there in the respiratory tract. And route of administration, obviously inhalational, using an inhaler, and very commonly they are combined with LABAs or long-acting beta agonists. Sometimes with corticosteroids also they might be combined. And mainly since it is given through inhaler, it can cause bronchospasm, irritation, itching, rash, or hypersensitivity reactions also. Alright. Now let us see leukotriene receptor antagonists. They block cystinyl LT1, leukotriene 1 receptor. That is the mechanism of action. There are 3 drugs in this class: montelukast, zafirlukast, and xylutone. Montelukast trade name is singular. So mainly it is used to treat obviously bronchial asthma and COPD. Apart from that, allergic rhinitis and exercise induced bronchospasm, generally not given. Instead, beta 2 agonists are preferred. And with the side effects, it causes CNS depression, neuropsychiatric symptoms like headache, restlessness, convulsions, tremors, mood changes sometimes, and most importantly, these drugs lead to suicidal thoughts as a side effect. And an important point is there is increased risk of Church-Strauss syndrome, where we see eosinophilia and vasculitis, and it is a very life-threatening condition, Church-Strauss syndrome. And with respect to xylutone, it inhibits 5 LOX or 5 lipoxygenase. That obviously forms leukotrienes and lipoxins. Not much used because of hepatotoxicity. And next, coming to mast cell stabilizers. So these are the drugs which are going to block the mast cell activity. So what does it do? Mast cell release histamine, and that causes vasodilatation. So that is not going to happen. The drugs in this class are cromolyn sodium, also called sodium chromoglycate. Apart from that, nedocromyl, NEDOCROMIL, and ketotifen. So as I've explained the mechanism of action, and uses mainly we have this allergic asthma, and apart from that bronchitis also it can treat. And with respect to side effects, it can lead to irritation, itching, cough, bronchospasm, headache, nasal congestion, and very importantly, a fixed schedule of administration is very important with mast cell stabilizers. And next we have the glucocorticoids, which are generally given to fight infections, even corticosteroids, but here glucocorticoids are divided into systemic and inhalational. Like systemic, end with the suffix, okay, so we have hydrocortisone, prednisolone, methylprednisolone. Inhalational, like beclomethasone, mometazone, dexamethasone, budesonide, fluticasone, and ciclesonide. So mainly they inhibit the synthesis of lipocortin, LIPOCRCORTIN, lipocortin, that won't allow the prostaglandins to make other products. And very commonly prednisolone is mainly used to treat infections. It can be given oral or IV also. Yes, and also apart from that, these drugs, they don't have bronchodilation effect Okay, they increase something called as annexin 1 proteins that inhibit phospholipase A2. It can lead to local and systemic side effects. So with the local side effects, it leads to mental retardation, easy bruising, hyperglycemia, and weight gain. With the systemic side effects, superinfections, dysphonia, etc. And mainly in superinfections, candida, mainly. That's the candida fungus that's causing the throat infections. And very commonly, glucocorticoids are combined with LABAs, long-acting beta agonists. And apart from that, it can also cause as side effects like GI distress, renal failure, osteoporosis, musculoskeletal weakness, hypertension, etc. And finally, we have anti-IgE monoclonal antibody. The only drug is omalizumab. So this is going to block the IgE action, which is responsible for hypersensitivity 1, where it's an immediate response, where there is a trigger of the mast cells to release histamine. So that is not happening. And where it binds to the mast cell, this is important, Fc epsilon R1 receptor. And local side effects are there like redness, itching, irritation, stinging. Also it can cause erythema nodosum sometimes, and omalizumab is not much given because this drug is expensive. So that was all with the drugs to treat bronchial asthma. So thank you so much. We will see in the next lesson.